This podcast does not provide medical nor legal advice. Please listen to the complete disclosure at the end of the recording.
Hello and welcome to Everyone Dies, the podcast where we talk about serious illness, dying, death, and bereavement. I'm Marianne Matzo, a nurse practitioner, and I use my experience from working as a nurse for 46 years to help answer your questions about what happens at the end of life.
And I'm Charlie Navarrete, an actor in New York City, and here to offer an every-person viewpoint to our podcast. We are both here because we believe that the more you know, the better prepared you are to make difficult decisions.
So welcome to this week's show. Please relax, get yourself something cold to drink and some pie, and thank you for spending the next hour with Charlie and me as we talk about the signs of ovarian cancer and what you need to know to get a faster diagnosis. Like the BBC, we see our show as offering entertainment, enlightenment, and education, and divided into three halves to address each of these goals. Our main topic is in the second half, so feel free to fast forward to that babble-free zone. In the first half, Charlie has the history of funeral feasts for us and a recipe you can take to your next funeral lunch. In the second half, I'll be talking about the signs and symptoms of ovarian cancer. And in the third half, Charlie talks about the documentary film Dick Johnson is Dead.
For our first half, in many places in the Sudan, meat and drinks are still brought to and laid on the grave so that the dead may enjoy them at their pleasure. It is believed that the ceremonies performed by the priests can change the offerings into a spiritual form which the dead partake, leaving the actual food to be consumed by the priest and the relations, which is a way to communicate with the dead. Some historians say that this practice can be traced in the Bulgarian custom of feasting in the cemeteries on Palm Sunday, where the remains of the meal served are left on the graves for the dead. The most ancient Egyptian and Roman ceremonies were connected with offerings to the dead: wine, sweet beer, cakes of various kinds, fruit, scented oils, the heads of bulls, and a variety of ceremonial garments were used for the purpose. The Chinese and the older civilizations hold fast to the belief that the spirits of the dead need some form of nourishment. These practices are at least partly rooted in the terror of being haunted by the ghost. The Bodo of India carry the dead man's share of food and drink to the grave and say, "Take and eat. Heretofore you have eaten and drunk with us. You can do so no more. You were one of us. You can be so no longer. We come no more to you. Come you not to us." After this recital, in order to make the changed position still more definite, each mourner throws on the grave a thread bracelet, which he breaks off his wrist, saying, "Take that. The tie between the dead and the living is snapped." A similar ceremony is performed at the funeral feast in the Solomon Islands, where a portion of food is thrown into the fire and the dead are told, "This is for you." When the Trappist monk dies, his meals are still served for him in the refectory for 30 days after his death, and then his plate is given to the poor. To the superstitious mind, a food offering should properly be served at the burial place. Otherwise, a danger would be incurred by tempting the soul to wander back to its former haunts, a thing which mankind has sought to avoid for millennia. And speaking of tempting food, our recipe this week is South Dakota Frito treats, which are ready in 15 minutes. So even if you decide at the last minute to attend a funeral lunch, you will be on time. They are Fritos covered in a mixture of corn syrup, sugar, and peanut butter, and covered in chocolate. You may even find yourself making these without a funeral to attend. Bon appetit! Please go to our webpage for this week's recipe for South Dakota Frito treats and additional resources for this program. Your tax-deductible donations are always welcome so that we can continue to offer you quality programming. Thank you in advance for making your donation at www.everyonedies.org. That's every, the number one, dies.org. You can also donate a bit every week to our site on Patreon. Just go to www.patreon.com and search for Everyone Dies. Patreon is spelled Patreon. Marianne?
Thanks, Charlie. Today's chat is about ovarian cancer. So, of course, I feel the need to talk about the ovary in general first. The ovaries, there are two, in females, and is located in the pelvis on either side of the uterus. Ovaries contain developing follicles which produce human egg cells every month and are also responsible for the excretion of the hormones estrogen and progesterone to keep the female reproductive system working. Ovarian cancer is one of the most common gynecological cancers, can occur at any age, and has even been diagnosed in babies, but is most typical in women age 50 and older. The American Cancer Society estimates for ovarian cancer in the United States for 2024 are that about 19,680 women will receive a new diagnosis of ovarian cancer, and about 12,740 women will die from ovarian cancer. The exact cause is unknown, but the risk of ovarian cancer increases with age, positive family history, being overweight, and the presence of other conditions such as endometriosis, which is the presence of parts of the uterus tissues outside the uterus. Malignant ovarian lesions include primary lesions that come from the normal structures within the ovary, and secondary lesions from cancers arising elsewhere in the body. Primary lesions include epithelial ovarian carcinoma, which is 70% of all ovarian malignancies. Current research suggests that the majority of this cancer starts in the fallopian tubes. The stage of disease measures how far a cancer has spread from its origin. In this case, how far the cancer has spread from outside the ovary. The staging system used by the Centers for Disease Control and Prevention and the National Cancer Institute is called summary stage. Summary stage characterizes invasive cancers as localized, regional, or distant. Localized ovarian cancer is confined to the ovary. Regional cancer has spread directly beyond the ovary, called regional extension, or to regional lymph nodes. And distant cancer has spread to other organs besides the ovary, called distant extension, or to remote lymph nodes. We went into great detail about staging in our show about stomach cancers, so if you want to learn more about that, you check out that show. Using the 2022 submission data, the CDC report that for ovarian cancer, 22% were localized at diagnosis, meaning they were only in the ovary. 23% were regional, and 49% were distant, and 6% were unstaged, meaning it was unknown or unspecified in the report. 1 in 7 women will die within 2 months of their ovarian cancer diagnosis. Now, if you're diagnosed in the earliest stage, 9 in 10 women will survive. So to put it another way, the proportion of women diagnosed with ovarian cancer who survive for 1 year ranges from 98% with stage 1, meaning just in the ovary, 91% with stage 2, mean regional, to 74% with stage 3, and only 56% with stage 4. Now, did you just say, wait a minute, what? 49% of women are diagnosed with distant metastatic ovarian cancer? 49%? How can that be? Why isn't that diagnosed sooner? Well, that's what I want to talk with you about today. The symptoms of ovarian cancer are considered to be nonspecific or vague and are often accepted by women as normal changes associated with aging, such as menopause. What I would hear from women frequently when they talk about their diagnosis is that they would say that they noticed that their waistbands were getting tight and thought maybe they just needed to watch their weight. I've heard that from a lot of women. Now, this is a dangerous misconception that can lead to late diagnosis and poor outcomes. Some women think that having a yearly pap test will also find ovarian cancer. This is not true. The pap test checks for cervical cancer. So cervix is the outside wall between the vagina and the uterus, the part that opens for the baby to be born. So the pap test only tests for cervical problems. I've had women tell me that they've had a total hysterectomy with both ovaries and the fallopian tubes removed 20 years ago. So they don't have ovaries, and there's no way that they can have ovarian cancer. Now, this scenario makes ovarian cancer less likely to occur, but it does not remove all risk. You still have a small risk of peritoneal cancer, and the peritoneum is the covering that lines the abdominal organs and is close to the ovaries. Cells in the peritoneum are very similar to the cells in the ovaries. When cancer develops in the peritoneum, it looks and acts like ovarian cancer. So don't think that this doesn't apply to you if you've had your ovaries and fallopian tubes removed. It's important that everyone know the symptoms that would need further investigation to rule out or rule in a diagnosis of ovarian cancer. The symptoms are persistent abdominal distension, bloating. Your belly is big. Some women will say they look like they're 9 months pregnant because their belly is so kind of blown out. They report feeling full fast or loss of appetite. They'll sit down to eat, take a couple of bites of food, and they say, I'm full now. And that's not how it had always been for them. So, when we're talking about symptoms, we're talking about things that weren't there before, that something has changed. There could be pelvic or abdominal pain, having to urinate frequently or urgently, that, oh my God, I've got to go right now, or I'm not going to make it. Changes in bowel habits, like having diarrhea or constipation, extreme fatigue, unexplained weight loss, unusual vaginal bleeding, weight gain from increased fluid in the abdomen. So you're losing kind of weight everywhere else, but you're gaining weight because your abdomen is so big. So these symptoms need to be frequent, and what we're talking about is more than 12 times a month. Persistent, meaning it goes on for a long time and it's hard to get rid of. And new, meaning it's not something that you've had for the last 20 years. So if you're listening to this and say, oh my God, I'm always tired. I've been tired for the last 30 years. Chances are you're not the person we're talking about. I'm not saying you're not. I'm just saying what we're talking about is new. There is a symptom diary that we have in the show notes that you can print off and mark off the symptoms you're having that you can take to your healthcare practitioner. And it's set up with these symptoms and then the frequency of them so that you can see for yourself. So if you go to your healthcare practitioner with your symptoms and they tell you that you have irritable bowel syndrome and you're over age 50, know that irritable bowel syndrome rarely shows up for the first time in women over the age of 50. So if you're over 50, you've never had that diagnosis, you start having these symptoms, you go to your doctor, they say, oh, it's just irritable bowel syndrome. Question that. Say to yourself, that would be unusual. Talk with your doctor about it. And if they kind of poo-poo you or don't take you seriously, which happens, and I've had many patients that's happened to, get a second opinion. Persistent abdominal pain or change in the bowel habits does require further testing. Having a normal examination of the abdomen and the pelvis does not rule out an ovarian cancer diagnosis. The tumors in ovarian cancer can be small and flat, and there can be metastatic disease without a large mass. So when doing that examination, they're very hard to feel. But ovarian cancer can also cause these symptoms and should be tested for at the same time that they're doing the workup for your bowels. This can be done by a blood test called the CA-125 when they're doing the abdominal exams. So this is a blood test, and the CA-125 is a tumor marker that's found in your blood. This tumor marker is released when the peritoneal lining is irritated. So talked about it's that lining that's within your body. It's the membrane that lines the abdominal cavity and covers all of the abdominal organs. CA-125 is not specific for ovarian cancer, as it acts as a marker for other conditions, but it's sensitive to what's going on in the ovary. There can also be false positives and false negative results of the CA-125. False positives can occur in other inflammatory conditions such as connective tissue disease, endometriosis, heart failure, and other abdominal cancer. Having the blood test while you're menstruating, while you're having your period, can also elevate the CA-125. So wait until your period is over before having that test. The CA-125 level is considered elevated if it's above 35. If a woman has a negative CA-125, meaning less than 35, but continues to have symptoms, there should be further testing with at least another CA-125 blood test in 4 to 6 weeks and a referral to a gynecologist. If the CA-125 is above 35, a transvaginal pelvic ultrasound is typically ordered. Now, this is a similar technology to any ultrasound exam, except they use a wand that's placed into the vagina so that the organs in the pelvic cavity can be viewed. It doesn't hurt, and it's the way that they're able to see those organs. Now, what happens next can be quite variable depending on your age and your overall health, where you live, such as if there's a cancer center near you with experienced surgeons and gynecologic oncologists, the exact type and stage of the cancer, and your desire to have children. For women of childbearing age who have certain kinds of tumors and whose cancer is in the earliest stage, it may be possible to treat the disease without removing both ovaries and the uterus. Now, typically after a cancer diagnosis, the first stage is surgery to remove as much of the tumor as possible. This is called debulking surgery, and it's also at this time that the cancer is staged, that is, seeing how far the cancer has spread from the ovary. Once this is done, your gynecologic oncologist will determine with you a treatment plan that may include radiation, chemotherapy, hormone therapy, targeted drug therapy, and/or immunotherapy. Having cancer and dealing with treatment can be hard, but it can also be a time to look at your life in new ways. You might be thinking about how to improve your health or relationships. While you can't change that you now are a cancer survivor, you do control how you respond to the challenges that you face. Consider joining a support group. Women in these support groups know what you're going through because they've gone through it themselves. You can have friends who support you, or a husband who supports you, or a partner who supports you. But talking with women who have gone through this can make all the difference. Charlie, any questions about ovarian cancer?
Yeah. Actually, Marion, before I ask, when you came to town, and the first time I met David, with the group, I'm sorry, I don't remember. Were you discussing ovarian cancer at that time with that group?
That group were ovarian cancer survivors, and I was talking about sexual health following that cancer treatment. Because, the surgery and the treatment, and if you have radiation, all of those things can really affect sexual health, sexual response, sexual desire. And many of the women who have this are young.
Yeah.
I mean, like I said,
Right. I remember, yeah.
I've seen babies who've been diagnosed with it. So you don't have to be over 50. Most are over 50, but you can be at any age. And so, I've had patients who were just married and then found out their diagnosis. And so they're thinking, oh, I'm a newlywed and there's things that go with that, and, planning to have babies and when that's going to happen. And with this treatment, unless you tell them ahead of time, I want you to work with me so that I can have a child, if it's egg banking or whatever, they can try to help make that possible. But so for a change in sexual response, and I think we've done a show, haven't we? We've done a show.
Yeah, we have.
Sexual health. Yeah. So make sure you listen to that if you're going through ovarian cancer treatment or been diagnosed, because there will be changes there. But there are things you can do. There's things that you can do to manage it so that you can still continue to have a healthy sex life that you want to have, whatever that is.
I brought it up because as you were saying about having a support group, I just remember these ladies, because they were all basically in the same boat, if you will. Just the way people were able to interact with each other, it just seemed to support themselves. It gave them some strength, and of course, with your guidance also, and pointing out this and that. And I will just still remember when with a couple of the women talking about their lack of that it was painful sometimes to have sex. They felt bad. They felt they were cheating their partners. And you just jumped in with the solution about, well, there's lubrication. And what did you say? You said there's either lubricant or
moisturizer.
There we are. Thank you. And you clarified the difference between the two. And I just still remember suddenly everybody was like a kid in college again, writing notes just to get this straight. And it was just that you just clarified that for people. But it's just that people just getting together and talking about this and reaching a solution. It's yeah. So to your point, it's just you're not alone.
Yeah. I facilitated the ovarian cancer support group at our cancer center for many years, and we buried a lot of women, and did a lot of projects with them, and my kids would volunteer at the different events that they would have, so they would get to know the ladies. And we had a thing at my house once where they were making the ovarian cancer color is teal, and they were making teal bracelets as I don't know if it was for a fundraiser for exactly what we were doing with them, but all these women sitting around making bracelets, and the kids were young, and my youngest, in her way, went up to one woman and said, "So does everybody here have cancer?" And this woman was astute enough to look at Juliana and say, "Everybody except your mom." And Julie said, "Oh, okay." Because I think her little mind was kind of like, so does my mom have cancer? Because all these people have cancer,
Okay. Yeah.
So I always appreciated her answer. And she's still alive and posting negative things about Trump on Facebook. So.
So, I mean, hang on. Shoot, I scribbled something down here. Okay. So you would mention about, it's, a woman might feel, how did you put it? Like, her, for example, that her pants or her skirt are a little tighter and think, oh gosh, I'm overeating. Um, but so, I mean, at what point would a woman think, this might be something different, or even think maybe it's not overeating and go to a doctor? I mean, is there anything else besides, oh, my pants are a little tight now, to give someone an indication that it could be something else?
Well, there's that whole list of symptoms that I gave you, and so I really would suggest that our listeners, look at or rewind the
Mhm.
tape and look at those symptoms because
Okay.
they're vague.
Yeah.
Anybody could have them. We can make an excuse in our heads for any of them. And that's what we do because we
Yeah.
don't
Yeah.
want
Yeah.
to
Yeah.
think
Yes.
that it's a cancer. So what happens is a long time goes by with you having those symptoms until you get severe pain or you get um, a, a blockage so that you can't move your bowels at all. Something happens. And then you go to the emergency room and you're suddenly diagnosed with stage 4 ovarian cancer because we ignore those symptoms up until then because in our head we can we think we can explain them away. I even had one patient in the support group who had been diagnosed with ovarian cancer, had all the treatment, went on all the rides. And I don't even remember how many years later, started having those symptoms again and ignored them again.
Mm.
And when we talked about it, she said, I just didn't think it would come back like that. But they were the same symptoms. So, you know, it's just, I think, humankind to just find another explanation. And so, what I want for our listeners is not to find another explanation, to say, God, I do look like I'm 5 months pregnant, and there's no reason for that. And I do, oh, yeah, and I do get full really fast. Well, get thee to thy doctor. And the other thing that happens is that women can go to the doctor, and the doctor will poo-poo it, or they'll say it's
Ah,
irritable bowel syndrome,
ah,
or
geez.
you're just under stress,
Right.
or why don't you try going on a diet? Yeah, your belly is big, instead of, oh, well, this could be this. I'm going to work you up. I'm going to do the CA120. I'm going to, address this. So it's sort of like a two-part um, blindness on our part as women, because that's not what we want to hear, and blindness on the part of doctors who,
Hmm.
primary
Yep. Yep.
practitioners who don't put two and two together and say, well, I don't, they'll say, well, I don't want to scare her, so let's just try this diet for irritable bowel syndrome and see if that makes it go away. Well, all that's doing is spreading out the time until diagnosis and giving the cancer more time
Right.
to be aggressive.
Ugh. Yeah. As you,
So for
yeah.
our listeners,
I'm sorry.
don't
What?
do that. I said, for our listeners, don't do that. Be a strong advocate for yourself.
Absolutely. That's what I
And
was about to say. Yes. Yeah.
okay, yeah.
Yeah. You have to. Yeah. Really. If you don't advocate for yourself, I mean, who else will? Yeah.
I mean, I had a time where I had to fly to DC to get an award, and while I was there, I had the most excruciating pain in my right side, and it would not go away. I mean, I
Oh, right,
cannot
right, yeah.
begin to describe how horrid that pain was. And I went, like to get the award. I mean, I was a mess and got on the plane to come home. And I'm thinking, oh my God, oh my God. I don't know what this is. And the plane landed, it kind of bounced as it landed,
Uh-huh.
and the pain went away. And I thought, okay, that was weird. But I went to my primary and I said, here's what happened. And of course, I'm working with these women all the time. So where's my head going to go? It's going to go to ovarian cancer. And he said to me, he was a good doctor. I liked him. He said, so what do you think is wrong? I said, I think I have ovarian cancer. And he looked at me and he said, I don't think you have ovarian cancer. I said, I'm telling you, it was horrific. It was horrible. It was right there and da-da-da. He says, okay. He sent me for a transvaginal ultrasound. And of course, well, thank God, that's not what it was. And his thought was it was probably a kidney stone.
Oh,
That when we landed, the change in the pressure and
right,
stuff
right.
kind of like moved it out and got rid of it. But anybody who gets kidney stones, my heart goes out to you because that was really horrible.
Yeah. Jeez. Yep. Yeah.
So I go the other way. This is what it is. We have to work it up right now. And he was like, okay.
There's one last thing. You mentioned, if a woman starts going to the bathroom a lot, it could be indicative of ovarian cancer. So let me ask you, in men, and I'm asking for a friend, if a man, especially older men, start going to the bathroom a lot, could there be indicative of some cancerous thing? Or is it just that, we're getting older and you just wind up peeing more? Your thoughts?
Oh, so you're talking about urination, not bowel, right?
Oh, yeah, I'm sorry. Yes. Urination. Yes.
Well, so there's a lot of things that can make you pee a lot. There's diabetes, would be like one of the first ones.
Mm-hmm.
Prostate cancer, which we're going to talk about in a few weeks, has sort of the opposite effect in that you need to go to the bathroom, but you can't get a stream out. So then the next question would be can you get a stream out, or does it start and stop? I mean, so there's a lot that can be worked up. My answer to that would be go to your primary practitioner and say, here's what I'm noticing. And, they can do a dipstick, see if you're throwing, if you're, passing if there's a lot of sugar in your urine, if there's an indication of type 2 diabetes, and get yourself worked up. It's like if you're saying, any of our listeners, if you're saying to yourself, this has been happening and it never happened before, but now it is, what is it? Well, it could be age-related, but it also could not be. And so err on the side of, going to the doctor and getting worked up and find out, because blissful ignorance is not going to keep cancer at bay if that's what it is.
Yeah, I love that phrase, blissful ignorance. Thank you.
You're welcome.
So moving on to our third half. When I say Dick Johnson is dead, your thoughts may wander to Richard Dick Johnson, part owner of the V8 supercar team, Dick Johnson Racing, and a former racing driver. As a driver, he was a 5-time Australian touring car champion and a 3-time winner of the Bathurst 1000. Johnson has claimed over 20 awards and honors, including the V8 Supercars Hall of Fame, into which he was inducted in 2001. And you'd be wrong. The real Dick Johnson is Dead is a documentary film directed and written by Kirsten Johnson. You can watch it on Netflix. While filmmaker Kirsten Johnson learned that her widowed father, Dick, a clinical psychiatrist in Seattle whose wife had already died of Alzheimer's disease, was losing his memory and could no longer live alone. So she brought him to live with her in New York. Their choice on what to do with the time they had left together is explained by the video librarian. Kirsten approached her dad with a singularly oddball idea. In order to help cope with the idea of his inevitable death, Kirsten would film numerous fictional sequences of her father dying, often in gruesome, macabre ways that would end with Dick miraculously resurrected back to life. Scenes include a fabulously decorated imagining of Dick in heaven, and a staged funeral in which Dick's real friends and acquaintances come to pay tribute to the man, who watches deeply moved from the sidelines. There is more than one way of dealing with grief. Questions of aging and mortality pop up through humor. The film also celebrates life as it points out that, well, everyone dies. We have a link to the trailer of the film in our show notes. Marianne, have you seen this?
Yeah, Dave and I watched it the other night when you told me you were going to do this. And first, Dick Johnson is just a sweetheart of a man.
Absolutely, yes, yes.
And different than, I think, anybody that I've seen with dementia, in that he's very cooperative, and he will say, well, if I say something wrong, it's just because of the dementia. And mostly, people with dementia don't remember that they have dementia, so that they aren't able to say, well, this is why I'm doing this, or this is why I'm acting this way. But he's a psychiatrist. Right. I don't know if that makes a difference. And in the earlier stages, which I know makes a difference. I mean, we don't see him in his late stages, so we don't know what happens, right. After that first couple of years. But what we do see is just a sweet, funny kind of guy who goes along with whatever his daughter wants, and is in all these interesting positions of being killed. And
yeah, it's like
I mean, it's one of those that you should definitely watch, and I think it'll resonate with some people, and some people will say, "What the hell was that?"
Yeah, there's and you can, and again, just in the trailer for it, just what you were saying, there's about staging different ways he could die. And in the trailer, it looks like he's fallen down some steps. His arm is cocked at a very uncomfortable 90-degree, and you look at that clip, it's like, holy shit, this is horrible. And you hear his daughter saying, okay, Dad, can you move your arm just a little bit more over your head? And it looks more gruesome. And she goes, oh, great, thanks, Dad, perfect. Very funny. But again, it's great because also it doesn't shy away from the fact that this man is developing dementia. And there's some of those moments which, are more, serious and to the point about that. Yeah. There's another one, the comedian, Sarah Silverman. Sarah didn't make a documentary about this, but she videotaped a few meetings with her father as he was preparing for the end of his life. He felt fine, but she went to see a couple of doctors, and this was filmed. And basically, it's the same concept, just not as graphic, but she would be insulting her father would be insulting her. You can just see the love underneath it. She didn't want him to die, but she wanted him, and he did too, just to die in the best way possible. So you might want to check that out too. So,
and I think that that's,
yeah, I'm sorry.
I think that's all we really want, is to die in the best way possible, and to, be with our children and share that with them in whatever way. Mm-hmm. And it's unfortunate that our culture and our fear of death keeps us from having that. And so the other thing I would wish for our listeners is that, give that to yourself. Don't deny yourself that those last months where you are openly and honestly talking with your kids
Yeah.
about here's the next thing that's going on.
And I would like to add to that, don't necessarily wait. Actually, don't wait until you're in that position where you're going to start, your body starts to fall apart. I had this talk with my mom and dad, and I told my siblings, yeah, well, I'll have the talk with mom and dad. Um, yeah, what a fool I thought. It was easier doing it with strangers. This was not my mother and father. It's like, son of a bitch.
Right. Right.
But it was great to. Thankfully, they had already discussed this, between themselves. So yeah, I was a day late and a dollar short. So yeah, don't wait.
Or
Don't
you
wait till the
or you could
crisis
be
hits. Yeah,
right. Or you could be my kids where you have a mother who's does what I do, and the talk of death is ever
yeah,
present.
it's everyday conversation at the dinner table. Yeah,
Or, I would get a piece of jewelry and, as a Christmas gift from a husband or whatever, and they'd say, "Ooh, I really like that. Can I have that when you die?"
they are your daughters. Yes. Yep.
So they've already, picking out their jewelry.
Very good. And on that positive note, and I'm not being sarcastic, on that positive note, thank you for listening to this week's episode. And please stay tuned for the continuing saga of Everyone Dies. This is Charlie Navarrete. And from writer-director Woody Allen, dying is one of the few things that can be done as easily lying down.
And I'm Marianne Matzo, and we'll see you next week. Remember, every day is a gift.
This podcast does not provide medical advice. All discussion on this podcast, such as treatments, dosages, outcomes, charts, patient profiles, advice, messages, and any other discussion are for informational purposes only and are not a substitute for professional medical advice or treatment. Always seek the advice of your primary care practitioner or other qualified health providers with any questions that you may have regarding your health. Never disregard professional medical advice or delay in seeking it because of something you have heard from this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. Everyone Dies does not recommend or endorse any specific tests, practitioners, products, procedures, opinions, or other information that may be mentioned in this podcast. Reliance on any information provided in this podcast by persons appearing on this podcast at the invitation of Everyone Dies or by other members is solely at your own risk.